A drug originally made for diabetes is now quietly changing how millions of American women experience pregnancy, birth control, and family planning. And the unsettling part is that most of them had no idea it could. All over the country, women on GLP-1 medications are reporting pregnancies they didn't see coming. Some had been told for years they couldn't have kids. Some had been taking their birth control pills exactly the way they were supposed to. Some were doing both at the same time and still ended up pregnant. It's happened often enough that the situation now has its own name. On TikTok, on Reddit, in private Facebook groups, women are calling them Ozempic babies. There's a Facebook group literally called I Got Pregnant on Ozempic, and it's grown to more than 600 members. Cleveland Clinic obstetrician Dr. Deidre McIntosh put it bluntly. In her words, it's not an overstatement to say we're seeing an Ozempic baby boom. What that looks like in everyday life is straightforward. Women who started a GLP-1 to lose weight or manage their diabetes are running into a reproductive side effect that nobody walked them through when they picked up the prescription. And this isn't speculation. The mechanism is spelled out right in the federal regulatory data. If you look at the FDA prescribing labels for Mounjaro and Zepbound, both made by Eli Lilly, a single 5 mg dose of tirzepatide cuts the total absorption of oral contraceptive hormones by 20 to 23%. The peak concentration of those same hormones drops even more sharply, by 55 to 66%. The reason is something called delayed gastric emptying. The drug slows your digestion down, which is part of how it kills your appetite, but that same slowdown also affects how your body absorbs anything else you swallow. That includes the birth control pill you take every morning. The FDA labels for both Mounjaro and Zepbound now spell out the protocol. If a woman is on oral hormonal birth control, she needs to either switch to a non-oral method or add a barrier method, and she has to do this for 4 weeks after starting the drug, and then again for 4 weeks every single time her dose goes up. For women on Ozempic, Wegovy, or Rybelsus, all of which contain semaglutide, the labels go further. They tell women to stop the medication 2 full months before trying to get pregnant, because the drug stays in the body for roughly a week after each dose and takes time to fully clear out. The trouble is, most women never hear any of this. There's an Australian study that followed 18,000 women between the ages of 18 and 49 who started a GLP-1, and only about 21% had any documented use of effective contraception when they got their first prescription. Out of roughly 10,700 women they were able to follow for at least 6 months, 232 of them got pregnant within those first 6 months on the medication. And then there's a second piece to all of this that makes things even more complicated. GLP-1 medications restore fertility. When a woman loses a significant amount of weight, her excess estrogen levels drop, her insulin sensitivity improves, her androgen levels come down, and ovulation can come back in women whose cycles had stopped working entirely. This effect shows up most strongly in women with polycystic ovary syndrome, which is one of the leading causes of infertility in the country. In one randomized trial, included in a systematic review of incretin therapies for PCOS, women on the GLP-1 drug exenatide got pregnant naturally at a rate of 43.6% over 12 weeks. The women on metformin, by comparison, came in at 18.7%. A peer-reviewed narrative review published April 22, 2026, in the Journal of Clinical Medicine summed up the combined effect like this. Restoring ovulation can raise the chance of an unintended pregnancy, particularly in women with obesity and PCOS, and that risk is made worse by the fact that this group already has a higher baseline rate of unplanned pregnancy to begin with. To give that some context, the Centers for Disease Control and Prevention reports that 45% of pregnancies in the United States are already unintended. So, the drug ends up working on both sides of the contraception equation at the same time. It makes the pill less effective, and it removes the biological barriers that were keeping pregnancy from happening in the first place. The scale of all this is moving fast. According to data from the IQVIA longitudinal prescription database, which tracks about 94% of all U.S. retail pharmacy prescriptions, GLP-1 prescriptions for young women between 18 and 25 jumped 659% between 2020 and 2023. If you broaden the age range out to 12 through 25, Women now account for 76% of every GLP-1 prescription written. A separate analysis in Diabetes Care, published in March of 2026, estimated that 24.6 million American women of reproductive age meet the clinical criteria to be prescribed a GLP-1. That's nearly half of every U.S. woman between 18 and 44. Meanwhile, the pregnancy safety data isn't anywhere close to catching up. The biggest study we have so far was published by Cesta and her colleagues in JAMA Internal Medicine back in December of 2023. They looked at more than 50,000 pregnancies in women with type 2 diabetes across several countries. Out of 938 pregnancies where the woman had been on a GLP-1 around the time of conception, the rate of major birth defects didn't come back statistically higher than what they saw with insulin. A smaller study by Dow and her team, published in BMJ Open in 2024, followed 168 women who'd been exposed to GLP-1s during the first trimester. They found a major birth defect rate of 2.6%, compared with 2.3% in a diabetic comparison group. The authors of that April 2026 review pointed out that while these numbers sound reassuring, the sample size is small, and not finding a problem isn't the same thing as proving the drugs are safe. And the animal data still raises real questions. Studies in rats, mice, and rabbits have shown dose-dependent drops in fetal growth, delays in bone development, and skeletal abnormalities, usually showing up alongside the mother losing weight. Mechanistic studies in mice have shown that semaglutide exposure late in pregnancy reduces both fetal and placental growth and changes how the placenta transports nutrients. That's exactly why both manufacturers' labels say to stop the drug the moment a pregnancy is recognized. The longest-running human pregnancy safety study, the Wegovy Pregnancy Registry, run by Novo Nordisk, isn't scheduled to wrap up until August of 2027. In the meantime, the gap between how often these drugs are being prescribed and how often patients actually get the warnings is showing up in the medical literature. The April 2026 review notes that conversations about contraception and pregnancy risk are still happening inconsistently in regular clinical care. Maternal fetal medicine specialist Dr. Manajay Kamyar told NBC's Today that her patients almost always say nobody walked them through the pregnancy risks of these medications. So you end up with a kind of clinical paradox. A woman is being prescribed a drug that improves her metabolic health, brings back her fertility, makes the contraceptive most women rely on less effective, and comes with instructions to stop using it 2 full months before any planned pregnancy. Instructions that, by definition, only work if she knows she might get pregnant in the first place. And for the women who do find out they're pregnant while on a GLP-1, the standard medical advice is to stop the medication right away. That decision creates its own set of problems. Stopping the drug is associated with weight regain and the return of whatever metabolic condition the drug was prescribed to treat. For a woman with type 2 diabetes, that means switching over to insulin in the middle of a pregnancy and going through intensive monitoring. For a woman who is taking the drug for obesity, it means dealing with the full metabolic rebound at the same time her body is trying to sustain a pregnancy. Prescribing keeps going up. The warning labels are still in place. The biggest dedicated safety study won't report for more than another year. And the group of people most directly affected, women of reproductive age, is the same group where use is expanding the fastest. If you want to keep following the real-world consequences of GLP-1 medications across health, cost, and access in the United States, consider subscribing to Dose and Demand. New reports go up regularly. Comments help shape what we cover next. So if anything in this report lined up with something you've seen in your own life, or in someone close to you, drop a note below. Here's one question worth thinking about. When a medication changes the body in ways that touch fertility, contraception, and family planning all at the same time, who should actually be responsible for making sure patients understand what they're taking? The manufacturer? The doctor writing the prescription? Or the pharmacy filling it?